Hello, Chris. Hello, everybody.
Guess it doesn't want to use my headphones this time. All right. So
We're live,
hey,
Chris.
I am live. Or did you ask if I'm alive? Yes, I'm alive.
Hi, everybody. Good evening. With us, Dr. Chris Prue, who's gonna be presenting tonight's webinar. I will leave it to you, Chris, so as not to delay any further. And we apologize for the few minutes late.
All right. So we'll get right into it. I'm Chris Prue. I'm the Director of Education for Digital. I know I might know many of you. I see some repeat offenders, as we call you, because you keep coming back, and I guess I haven't bored you yet. Or maybe I have, and you just don't have anything else to do. So welcome back. It's been, what, 4 months, I think, since we started. So Happy New Year to many of you, and almost Happy Chinese New Year coming up soon, I believe. And so this is the recurring webinar series. So this is the one that we have been doing monthly. It's product specific, so it's more sort of on the aspect of training, certainly some education. So it's geared towards people that basically have the product, because I'm not going to teach you how to collect an analysis or go through the data acquisition process or talk about the equipment or the system per se, but it's really focused on the analysis part. And what we do every month is we choose a different case study or topic to sort of highlight, that aspect and make it a little bit different, more enjoyable, hopefully, and a reason to definitely come back. So this month, I'm looking down at my screen because I need to share something here. I'm going to share my screen. I'm just going to do the whole thing. And be able to make this thing. So this month we are. Let's change the title. This is walking. Um, and so really this could, it's not that dissimilar to, say, other neurological conditions, or in general, and how we sort of evaluate and monitor. So I kind of wanted to start here just with laying a little foundation and seeing sort of maybe where it fits in, and a little bit about the literature, and maybe some of the limitations as well. So really the gold standard right now is it's variable. So we do a lot of clinical aspects, and there's no one single way that we tend to diagnose Parkinson's disease, and there's a lot of subjectivity to it, meaning that it's sort of opinionated, and we use a variable approach. So we have to collect data in various formats, and so there's a little bit of maybe lack of objective data in a complete diagnosis, at least from the earlier stages, and having certain biomarkers. We have some difficulties in drawing blood and determining the diagnosis based on something like that. So at least during the early stages, there can be some error associated with that. Also, it's a changing. It's a very dynamic disease where the things that are impacted are variable throughout, pretty much progressive, so they have a tendency to kind of get worse. So there's cognitive deficits and as well as motor deficits. The literature recently, in the last decade or so, has at least been showing us that the motor deficits may present themselves schizophrenia and the cognitive deficit, which gives us some implications that, those of us that work in the conservative physical medicine space may have an opportunity to pick up some of these conditions a little bit sooner. And in fact, some studies have been shown to diagnose very early stage, even preclinical Parkinson's disease using algorithmic data evaluation. We're not going to get into that at this point. I'm going to show you more so the spatial control parameters and biomarkers that we can look out for. We're moving in that direction, and I think there's some really interesting opportunities to come. And there are several algorithms that have been established and are being worked on. And so related to that, they're actually very, very high in accuracy and sensitivity. And so that's a wonderful thing, because the sooner that we can determine the condition, the better that we can slow the process and really improve the quality of life. L-DOPA is the most common intervention, especially during that early stages. And we typically pick that up as a result of dyskinesias or abnormal movement patterns. And so we can also use those movement patterns like gait to basically follow, the changes, the progression of the disease, certainly, as well as what it is that the intervention is doing to that particular person. So with at least the most available, not getting into algorithmic or multiple regression approach to some of this nonlinear approach, from a linear aspect and just looking at some of these biomarkers and spatial temporal parameters, you do see that typically there's going to be a lower cadence. And the reason for the lower cadence is also because it's going to be a lower speed, a slower walking velocity, stride duration, stance duration, some increase in Parkinson's disease patients. And we also see differences in the swing phase and the swing duration that tend to go down, so they move very, very rapidly. They're going to spend more time typically in stance phase as a result of that. As I said, the decreased walking velocity, the step width and the stride length and the overall swing velocity also tends to decrease in the early stages. Weirdly, it changes a little bit in the later stages, especially as we see an even shorter stride length. And to compensate for that, they tend to have a rapid velocity and increased swing stage velocity. And I'll show you something like that, and it's really evident on things like the treadmill. And because you're moving faster, that relative percentage of the swing phase is going to decrease, and the stance phase duration is going to increase. So this is a study that was presented at a conference by some wonderful folks at Aristotle University, Pathologies, and just to show that our system, our technology.
Chris, I'm sorry, I have to disturb you a little bit, but it seems, I thought it was only me, but it seems I can read some comments that the sound is not very clear. It's like the microphone is vibrating a little bit, or there's some interference. So the guys are not able to hear very well.
Yeah, let me check that for a second.
Okay.
I think I might know.
How's that?
Yeah, much better. I think, yeah.
Yeah, Livestorm doesn't want to use my my headset, so
Okay, but now we can hear you very well. So
choosing a little different audio pathway. All right.
Even Victor's saying much better. So yeah, not only me.
All right. Let me go back to sharing the screen. Is there anything that I need to repeat, you think, or?
Maybe the last part, just or a brief summary like that. Nobody has missed anything. Yeah. And for the guys, I mean, if you have any questions, you can ask directly on the chat here, or you can go to the questions tab down on the right side, and you can ask your questions. And we will pass the questions either as Chris is going or at the end, whatever you think appropriate, Chris.
Yeah. Okay. So just real quickly, I mean, some of our challenges are the diagnosis of Parkinson's. A lot of it, there's a lot of subjectivity to it. Movement disorders actually can happen much sooner before cognitive disorders, and we're getting better at evaluating that. And one of those is gait analytics. And so there are several algorithms in place that have been tested. And not only can we potentially diagnose Parkinson's disease several years earlier than consistent clinical methods, so we're able to actually capture that at a subclinical level, and then with those multiple regression or nonlinear approaches, then we can follow it much more. That's not our goal today, so we're not gonna get into that. But what we can do and what we do know is with spatial temporal parameters and markers, there's a great opportunity to still be able to evaluate and monitor the patient progress utilizing what we have. So things that we're going to look at are the cadence, the stride duration, stance duration, swing phase, swing duration, speed potentially, which we'll look at in the propulsion rate or ratio. The simplest and easiest one is decreased walking velocity, step width, stride length. We don't look at step width, but the stride length and the swing velocity, also with circumduction, has a relationship potentially with step width. But so we'll look at that. And so what I was talking about here was our system has been evaluated and used in the evaluation of Parkinson's gait. So we do know that we're capable of evaluating it. So with our particular system, the metrics that we'll look at here: walking speed, cadence, stride duration, stance duration, stride length, percent swing phase, circumduction, foot progression angle, toe off angle, heel strike angle, and increased contact variability. It's a lot, but you can actually create, and I'll show you here in a second, that you're able to create some of your own custom filters. So, you can draw your attention to some of those things. And then I think the biggest part is to do the comparison from one test to another to look at what's changed. And I started off by saying, which maybe you couldn't have heard me quite as well, but it's not that dissimilar to, monitoring and evaluating any of these conditions using gait analytics, especially when we look at some of the pre and the post. So as many of you know, this is the online software app. I use this a lot. So after I just did a training for another clinician, and I said I use my mobile device to collect, but I always bring the patient to the computer to actually show them the information, because the computer app is a little bit more robust. It has a little bit more information and some more things that you can do. This is the default home screen. If you look over here to the left, you can click on the patients and pull up and populate all of your patients. If you don't see it on that first screen, you can actually change the number of rows that's going to be displayed, or just simply click and go to the next page. Okay, so what I did here, so we've got multiple tests. And so this first one is actually considered sort of the normal or baseline. And what I was explaining to this other clinician, for example, is, I just do a walking test on everyone. And I think of it more as a baseline test that we can use to evaluate systemic changes, to a person, depending on your practice. I mean, I tend to see people for years and years and years. And so I have that kind of data. But even then, having a baseline walk data, because walking has more normative values than most anything that we have in terms of gait analytics or other forms of locomotion. So even if it's not used for baseline and it's part of the evaluation process of an incoming patient with a pathology, you can still use it to match up against the normative values and identify some of those abnormalities. So for example, even in the studies comparing Parkinson's gait to healthy subject gaits matched for age and gender, then we can actually identify, some of those consistent types of metrics and values that we would expect to see in a Parkinson's patient. And as I was saying earlier, in those algorithms, we get more detailed evaluation in looking at how the interaction of those things sort of filter into an earlier and more consistent diagnosis, where otherwise, you may not see gross motor changes in certain metrics, but if there's enough small ones that occur in those different areas, that's where that algorithm comes into play and really helps us out with that early determination that otherwise, we're not really capable of doing on our own. So I just put in the name of the patient as Parkinson's disease. Across the top, you have your dashboard, patient file, practitioner analysis, and evaluation. So you can click on any of those and it's going to highlight and bring up that specific. So this is the dashboard. It shows us the most recent evaluations. So again, I'm going to choose this one here, and it's going to pull up that specific analysis. We also have across the top here the summary, but up here, I've gotten into the habit, especially when I have multiple analyses, and sometimes, I may have someone come back for a different problem, and you can either create a new patient profile with their new condition, or just make notes. So you can actually edit and rename the analyses to whatever it is that you would like to call it. In the summary here, we've got pains. So this is information you can put in when you take the analysis. You don't have to put it in, and you can put in a Likert scale pain value. You can also put in the location and some of the other specifics related to that. I don't have it here. Walking aids. I think this is important because if they've been tested with a walking aid and you want to repeat that test or make note that this follow-up test was not using a walking aid because they improved. I mean, those are really important things. As far as controlling the variables, if you've been to some of these in the past, so I've done a couple of these, looking at the influence of footwear on gait patterns. And so to control that variable, putting in the pair of shoes, the type of footwear that the person was wearing, I think is also going to be important, because then, some of the differences may be as a result of differences in footwear. The metrics across the top, so embedded in the system, has normative values for walking based on the demographics and anthropometrics of your patient. So their age, gender, height, weight, foot size, and things like that. So that stuff's real important to make sure that you put in appropriately. And the system will automatically use a color configuration to determine its relationship to the normative values. So for example, we're looking at symmetry here, which is the time frame from foot contact through the end of swing phase. So we're comparing the right to the left foot, and we see that it's represented in green. So in green, it means that they're within the normal standard deviations of the normal population. And then we have amber and red. Amber means it's slightly outside of the normal, and then red means it's way outside. So if it's green, you don't have to spend a lot of time looking at that. I mean, I still do, just to see what it is in terms of looking at the values, but it lets us know that it's within the normative values. The reason I still look at that is potentially you may have someone at the higher end of normal values on the right side and the lower end of the normal values on the left side. And that may be worthy because we're talking about, asymmetries. And this is the one symmetry characteristic. But when I look at the other metrics and biomarkers, I still do that, at least in my mind, looking at those relative differences, because if, for example, in foot progression angle, one side is at 2 degrees, the other side is at 14 degrees, they're both within, 2 standard deviations of a normal value, but they're pretty different in terms of symmetry with regards to those. And at least, make note of that and decide whether or not you need to further investigate from a clinical perspective. But in the biomarkers and metrics that we have normative values for, it'll be represented in green, amber, or red. Typically in Parkinson's, we may not see any differences in symmetry ever. You may occasionally see some differences, especially if there's a dominant side that they seem to be holding on to a little bit longer, but it wouldn't be unusual not to see. So this particular evaluation is a baseline and is basically normal. We see that cadence is a little bit on the low side, and I'll talk about that in a moment. We see that speed is not only within the normal value, but that they're within a good speed. And what I mean by that is speed is an overall health metric as well. And so people that tend to walk slower, especially when we see this in older adults, it's an indication of increased mortality, which means that they're going to die sooner. So it has an overall health implication to it. So speed in general is kind of important as well as symmetry. The reason that cadence is a little bit low on this is because this person has a really good stride length, a relatively long stride length, but it's within normal values of a stride length of the person of that particular stature or that particular height, because we see that's going to be in green. So when I scroll down here and I look at the walking profile gives us right and left orientations of these spatial temporal parameters in gait with regards to the stride length and the relative percentages of the stance phase and the swing phase for both of these feet, and then also the time spent during double support. And so we see that, these values in green, 65.7 inches. It's in imperial. And then we see 61.8. So this brings me to that point that they're both within normal values of stride length, but, we see that this person, they have about a 4-inch difference, which is about 10 centimeters between stride lengths of the right and the left. Maybe there's something there, maybe something is not, but like I said, it's up to you to decide whether or not that's going to be, relatively important. We scroll down a little bit further and we see the gait line. So the gait line is the center of pressure. Our sensors do not have force transducers in them. We are able to provide the gait line based on a correlation to the studies that were done in the development of the product relative to using force transducers. And it has a very high relationship to the 3-dimensional foot orientation in ground contact, which we're going to look at in the pronation and supination. So it provides us the relative trajectory of that center of pressure from foot strike to foot flat into that toe off position. We also see that it provides the relative percentages of each one of those phases during contact phase. So we can actually break that down. And we see that they're all in amber. So slightly less on the loading phase and the toe off phase, slightly increased on the mid stance. So this is in relative, which means that it's going to be a percentage. You can also click on the absolute, and the absolute is actually going to give you the specific values measured in duration in milliseconds, right? So if that was of interest to you, then you can see what those are going to be. And some people question, well, how did I go from amber to, green and red in some of these? Well, remember that the relative was just a percentage, right? But we see that when we're looking at the absolute, those time frames consistent with normal gait might be a little different than what we see in the relative. In other words, the heel strike and the toe off are normal in terms of overall time, mid stance is a little bit longer. So in other words, the duration or the stance phase of this person overall potentially was a little bit longer. And I'm going to go back up a little bit here in a moment to look at that in a second. So most people will just look at relative and identify it as a percentage. The propulsion rate or ratio. So this is, it's not controversial, but you need to kind of decide as a clinician, where it's going to be impacted. But if I start to see especially double digits based on the sensitivity of this particular metric or marker, then that's when I'll start to decide whether or not there's something, relevant that I need to investigate a little bit more. But what propulsion rate is, it's the ratio between the hip flexors and the plantar flexors. So your hip moving that leg into the swing phase relative to the plantar flexors in toe off position, or propulsion, and which one is adding the appropriate amount. So there is a ratio that's supposed to be there. I use it a lot, if I'm dealing with someone with low back pain, for example, they will have a tendency not to engage their hip flexors, and we'll see that higher percentage in the plantar flexors. We see this one is just 11% on that right. To me, that's not that much of a difference in it. It could be something else. Although, let's think about that for a second. So when I go back up to the top here, we do see that their stride length, like I said, was 10 centimeters shorter than the left side. So if they were doing a better job at engaging the hip flexors, they'll probably have a better stance phase. So maybe they have a hip problem, could be part of the beginning of a neurological issue. We need to further investigate that. So in this walking profile, when I click on the advanced, I can now break this down into the stride duration, the stride length, the swing time, and the stance time. So not just the percentages, but giving me some of these absolute values. So we see that the stride duration is definitely longer on the left. It's a little bit shorter. It's long enough because the person is taking relatively long strides. So if we look at the stride length, they're both normal, but like I said, it's especially on the high end of normal of that left side. We have a tendency, functionally, neurologically, motor-wise, to try and correct for these things. And that's where it can sometimes be a little bit challenging if you're, using a stopwatch or just looking at this visually in identifying, where the problem is. Or some of the other devices or products, one of my previous devices, it doesn't tell me where I was too long or too short. It just told me that there was a relative difference. This actually provides that. As I mentioned in the gait line, when we clicked on the absolute values, right? When we clicked on the absolute values, it changed and we saw that foot flat was red. And this is actually represented when we look at stance time. Overall stance time is increased in both sides, right? So that makes sense. That's why this is in red, because they're spending a little bit more time on the ground in contact time. So again, gives us some more information if you needed to break down and look at some of those details. So I'm going to go back up to the top and we can look at some other markers here. I click on details. I find this of particular interest because it gives me the foot orientation in ground contact. So this is a little bit different than if you were looking at pronation and supination from the barefoot perspective, or looking at it from the mid to forefoot perspective, where that multi-triplanar, axis actually occurs. So we're looking at this from a foot perspective in a shoe. And so these values are specific to our system. And so our normative values have been measured and presented here with all of the tests that have been run. So what we see, same thing, green, amber, and red. So in the middle on this graphical representation here, we see this green corridor, as we call that. And we have the right and the left, and they're presented as mirror images, right? Just like how your foot would work. And so that green corridor is considered to be the normative values of the the contact phase during these different moments in time. So we've got 4 different moments. We've got foot in, which we represent as heel strike, and then we've got foot flat or toe down, and then we've got heel lift, and then we've got toe off as we're in late contact phase, getting ready for propulsion. So we have angulation data of each one of those, and again, that green corridor. If you put your cursor over one of those dots, it gives you the specific numerical value. And then it gives you min and max, which actually is the standard deviation. And we get that for all of these dots here. So we see that the pattern is fairly consistent and it's a fairly normal pattern. What I think tends to throw people off is they look at the written words here, and they think pronation, supination, and when you toe off, typically the foot goes back into supination, not towards pronation, but the foot as a whole relative, and if you think about it sort of as a block model in eversion and inversion, so it's a bit of a mix between those things, but in any event, it's how the foot is responding in a shoe relative to the ground surface. So that provides some interesting data. The other thing, when you look at these 2 lines and that standard deviation, they shouldn't be too wide. They shouldn't be, crouched up against. We should have some variability. And if you think about it from the perspective of like heart rate variability, then that's, the complex motor theory tells us that we don't want to be of 0 variability because we're not able to respond to changing environments is the concept behind that. And we find that here with movement patterns as well. Go a little bit further down and we look at foot progression angles. The foot progression angle is the angle of toe out or abduction, external rotation. And so normative values, it's pretty variable, but they should be fairly symmetrical from one side to the other. We've got 4 degrees and we've got 0 degrees. Not that much of a difference. And again, depending on the length of time that you actually took the test, that can influence some of that data as well. And then we have circumduction. So that's the displacement of that hip from that sagittal trajectory or that sagittal plane when someone is walking forward. And we see that it's very symmetrical and that there should be some level of circumduction. If there's too much circumduction, especially with a greater foot progression angle, they might actually have something going on with their hip. Oftentimes that's a strategy, even people that have knee conditions, to potentially decrease some of the moment of force at that knee, for example, if they're starting to experience some osteoarthritic conditions. And then we've got steppage and clearance. So this is the angle of the foot in a shoe relative to the ground surface. And if we think about that for a second, and I always get the question, can you put these in high-heeled shoes? And the answer is yes, but just keep in mind, it's going to measure the angle of the foot relative to the earth's surface. So if they're in a very high heel shoe, they're going to be starting off in a very high position to begin with. So some of these angles may seem, relatively high or relatively low, depending on what exactly it is that we're looking for. I try and test people in neutral shoes, and or if they're wearing a type of footwear that they have to for employment or sport, then that's what we do. So we get angulation in toe off as well as heel strike. And we see that we also have toe clearance in here. So remember some of the characteristics that we wanted to identify, in the Parkinson's patients. And what I'm going to do is now I'm going to show another feature. First, we're going to take a look at this filter. So the filter feature has a few that's in here, but what I can do is I can click on and I can create a custom filter. So if the literature, and as I've shown you here, has identified specific metrics that are most important at following for monitoring process or evaluation or diagnosis, I can actually click these specific metrics here. And that way, when I create that custom filter, I can just click on that custom filter and it's going to show me only those metrics. and draw my attention there because those are the ones that I might be most concerned with. So the next thing I'm going to do here, upper in the right-hand corner, we've got these 3 dots. If you click on that, it brings down a drop-down menu. I can rename the analysis. I can do a comparison. I can export the PDF. So exporting the PDF allows me to print this as a PDF or save it as a PDF, and makes it much easier for me to either send to the patient, another caregiver, or another healthcare practitioner or coach, if that's allowed. But I can remove all of that, information that maybe some other people shouldn't have access to. So here in the United States, it's referred to HIPAA, partly controlled by, say the FDA or MDR in Europe. So I'm going to actually click on compare because I want to show you this sort of next step. So if this was a person that was fairly normal and didn't have, the condition of Parkinson's disease, I'm going to click on this next one here. And now I can put side by side, two of these different evaluations. So now we see that, symmetry hasn't really changed. Cadence hasn't really changed. We do see a slower walking speed, however. So if we think about the progressive, nature of some of these neurological diseases, some of them can be a little bit more difficult to evaluate if you're not getting into a lot of the details. And again, this is where some of these biomarkers and metrics come into play, especially when we start to get into the algorithm. So still within normal value of 2.6 miles per hour. And again, that's relatively important because that's a speed that has also been shown to equate to it's pretty good still for health, right? So they haven't fallen into that slower walking velocity where it's going to have a negative impact on health. So now we can do a comparison of the walking profile. So 65.7, and now we're at 61. And then we've got 61.8, and now we're at 57.5. That would be a normal expectation. If you're walking slower, you're probably going to have a lower stride length. But here's what's interesting is potentially if someone, and this happens a lot in some of these more progressive conditions, especially neurological, is the body will try and compensate. So in other words, if a person's very confident in how they typically walk, and if they walk regularly, they will try and maintain that same pace. What will happen is their stride lengths will start to shorten and their cadence will go up initially, and that's how they're going to compensate for that. So that would be something interesting or worthy to note because, there's a direct correlation between stride length and walking speed, and actually walking speed is a product of stride length and cadence. So if you're going to try and maintain the same speed and stride length decreases, cadence is going to have to increase. So that would be something interesting to find out and really early, to potentially see. We see that the foot orientation hasn't really changed a whole lot with regards to the center of pressure. In progressive neurological disorders, it may not change. It will start to change as we see getting a little bit further away or a little bit more progressive. And the reason for that is the step width starts to change. The orientation of ground contact or foot in, heel strike position will start to change. And that's going to have an influence on some of that ground contact position. And we'll look at that here in a moment as well. We don't see really any changes in this propulsion rate. And you may not see that, at least initially. What will happen is that propulsion rate will start to change in progressive Parkinson's because their swing duration and their swing velocity actually starts to change. So let's do a comparison and look at these, two graphs. So this is the earlier one. This is the late one at 2.6 miles per hour. Again, not much changed. There's not a lot of difference between the speed, so I wouldn't expect a whole lot of change. And we see here, again, the foot progression angles and the circumduction really hasn't changed. We start to see some slight differences here. Stride length is changing, which also means that typically the toe off or propulsion is going to change. and the position on heel strike or foot in is going to change as they start to shorten that stride length. So that's how we can compare two of those. Now I'm actually I'm gonna change this up a little bit, and I have to look closer. I took my glasses off while we were away, and I wasn't seeing you all. I fell off the back of a boat when we were fishing, and I lost my good glasses, spectacles, and then I had to use my old ones. And I coach basketball, and last night I got hit in the face with a ball, and it popped out one of my lenses, and so I had to glue it in, but so I can't wear them right now. Anyway, enough of my problems. So this is definitely later. So what do we start to see here? Well, we don't see really a lot of change in symmetry. And again, you may not see that in some of these Parkinson's patients. We do see a decrease in walking speed. And it's a cause and effect. I mean, there's a lot of, neurological implications and dyskinesias going on in their movement patterns. And if those are happening, they can't perform in the same manner as even if they wanted to. Obviously, we also start to see a cognitive decline, and there's a lot of relationships between cognition and movement patterns, more specifically with gait, because there's a lot of reflexive nature and involuntary aspects in gait, and why gait works so well in evaluating conditions. So we see at the normal walking speed, we've got a much longer stride length. So now we're in the red for stride length. So their stride lengths are too short relative to this person's stature, age, gender. And we start to see that they're shrinking a little bit, and the symmetry is still there. So there's really not a difference in symmetry. The stance phase is increasing, which is again something that we identified as a representation in Parkinson's. We don't see a lot of changes in the gait line, at least right now. What we are seeing here is they're not getting as much propulsion. And I'm sure most of you have seen a video of Parkinsonian gait patterns. They tend to start to shuffle. So they don't have a lot of toe off or propulsion. And because their gait pattern has shortened in terms of stride length, that they're not going to be using their plantar flexors as much. And we'll see that the angulation also starts to reduce with regards to contact for heel strike. So pretty normal with regards to their foot orientation in the normal walking speed. And now we start to see some differences, right? So they're not going to have your typical heel strike on the lateral aspect and then transition it into a neutral, foot flat position and then back into that toe off position, because now we're starting to see that abnormal pattern with regards to their toe off and their heel strike position. And we start to see some differences, at least in the foot progression. It's reduced on both sides. And so typically you're also going to see some differences in the stance width as well during the gait pattern. Okay. Now looking at the clearance and the steppage, we start to see a very dramatic decrease in that toe off position for sure. And we continue to see a decline in that heel strike position, right? You're not going to need to heel strike with that great of an angle if you're not taking that far of a stride. All right. Now I want to show you one last thing. So I'm just going to go back to the first one. Oh, I guess I didn't have to do that. So one really cool feature is if you click on the evolution. So the evolution will take all of the analyses and put them into a graphical representation. So now you're actually plotting all of these in one place. If you put your cursor over each one of those, it gives you the values for that specific test. But then we have a global value up here. So on the last test, we do see a decrease in that symmetry. We see a continued decline in cadence. Now, a quick note about cadence. Cadence can be impacted. Well, some of these can be impacted when you're using a treadmill. I did use a treadmill, it's probably not advisable to use a treadmill with people that have neurological disorders unless you have a harness. Okay. But know that, for example, their self-selected speed, you're choosing it with a treadmill. So we will typically, okay, let me know what's comfortable, right? Go up a little bit higher, no longer comfortable, bring it back down to where they're most comfortable. Okay. Now, treadmill will especially impact some of the angles as well as stance phase and swing phase. But we do see a decrease in the cadence. Interesting, like as they start to slow down, the cadence will remain for a period of time, especially if you're using a treadmill. Speed is a constant decline. Now, this is looking at it from the perspective of really no intervention, so to speak. The way that we can monitor this or utilize gait analysis with the intervention is we should start to see some of these deviations. If there's a decline in certain aspects, there could be an increase in certain medications. I didn't mention actually, one of the other early stage interventions is also transcranial pulsed electromagnetic stimulation, which has some really interesting and promising effects to it. Another one is extracorporeal shockwave therapy, focus shockwave. So we may actually see some increases, or the decline in some of these parameters, won't be as drastic as if there was no treatment or intervention whatsoever. Similarly, as you can imagine, we see a decrease in the stride length. So swing time, interesting, on a treadmill, and even not on a treadmill, can potentially decrease. It initially can decrease, and then it may actually start to increase, especially on a treadmill, because they have to make up for that. Remember that on a treadmill, that belt is moving no matter what. So if they're going to fall if they don't take that step, and we can see that also can impact the stance phase. This is classic, your propulsion rate, a decrease in propulsion with the plantar flexors and an increase in recruitment by the hip flexors. And again, it's not because they're taking really long stride lengths and they're recruiting more musculature for that. It's because they're not doing that toe off position, because their stride and steps are relatively short and they're doing more of that shuffling gait. And biomechanically speaking, that's going to come from hip flexors. And the other things that you'll see too is they're not going to flex and extend at the knee as much. And also they look like their arms are swinging less because they are, and they may not engage their upper extremities at all during a gait pattern in those later stages as well. You can also click on the advanced to look at some of these more advanced features and what's going on. This is also what we saw, was a decrease in that attack angle or foot in angle. We saw a decrease in the clearance. As you can imagine, that shuffling gait, similar to an elderly patient who's at fall risk, that clearance is a big problem. Even aside from the other factors that we see in Parkinson's, like freezing, which also has implications to a fall risk profile. Okay. So we're under the 1 hour mark, so I made it. Let me come back to this here. All right. So there's a questions section. If anyone, has any questions, comments, concerns. We got the chat here too. Nothing yet.
There's Robin typing, but so far no questions.
Got a couple people typing. So future directions, eventually the filter system. Well, we use a lot of algorithms in our programming anyway. That I think the filtering is one step closer to that process of using specific algorithms for pathologies. But it's a conglomerate, right? So I think that's what's challenging for some people is, it's difficult. I mean, maybe gait analysis is challenging enough as it is. And it takes a little bit of practice to identify some of those things. Like I said, some people see some information in the green. I do too, but when I see that much of a difference between, two greens of the right and the left foot, definitely something to take into consideration. I love looking at variabilities and asymmetries, but some of these conditions do not have asymmetries. But what was interesting is just seeing this progression. Walking speed is a really simple one that people can start with. Self-selected walking speed, preferably is not being on a treadmill, but nothing wrong with using a treadmill. We just set the speed. I hide the speed. I don't want people to know what speed they're at because they maybe put it in their mind and they may remember what they were at last time and prematurely try and get to a certain speed. Is this system available in South Africa?
Yes.
I do believe so. Actually, we have a lot of folks from South Africa here.
Yes, we do have a distributor in South Africa. I'm gonna add my email here in the chat, so you could reach out to me and I'll connect you to them as soon as possible, as soon as tomorrow.
Another question is, how do you see freezing in the measurements? That's one of the limitations is we don't. In fact, the way that the firewall is set up for our system is how it detects the gait pattern is when someone stops. This is why we're able to use our system in small spaces, is that someone can walk, maybe your corridor is only, 7 meters long. They have to turn around and walk back another 7 meters to get the full 30 seconds or more. It does not pick up. It drops that data that was during the turnaround time or the stopping time. So it does not actually collect that data. So in our current system, we do not do the freezing measurements. And keep in mind too that this is an in-clinic system. It's not something that the patient takes home and wears. This is an in-clinic gait evaluation. Future potential projects that might be worked on now are the home version to evaluate patients in their home setting. And there's some interesting studies on that because if they're in a hospital system, patients have a tendency to do pretty well, better, just because there's accountability and responsibility and access to the healthcare practitioners, and then when they go home, maybe they don't do as well. But there are some studies that show that with some information, then they could possibly be able to either signal their healthcare practitioner, or when they come back in for a follow-up, we'll know exactly what people are doing. But that's not this particular product at the moment. Do you use the measurements for queuing if you cannot see or measure freezing? Again, they're not really going to be wearing this. What again, the limitations are such that the only time that you're actually going to see them freezing is visually, if that happens in the clinic. You could make note of the distance that they're able to cover or something like that. Maybe you'll identify if you look at the analysis, if there are some orientations that change rapidly, or there's a lot of variability in there that might provide you something, and potentially some other interventions, maybe even some orthoses or something like that. But as far as those later stages are concerned, this is really just going to be for the in-clinic evaluation on that progression. I think it's most valuable in the earlier stages. The later stages, it's, I think, easier and much more visual to see some of the issues that's going on. Let me go back to the other here. session. Can step length also be viewed? Oh, yes. So in the settings, you can change imperial versus metric. So that way, all of your data can be in the metric system. Absolutely. And speed. Yes. So you get speed as well. Hello, Theodore. Can you share some examples of references mentioning normal values? We can send that to you. So we've got the values other than the contact stages are from the literature. So we can send some of the references that we've used to establish those normative values. And Theodore, I'm sure we will be talking at a later date too. Oops. That's my emergency dog that tells me someone's here. All right. I think that's about it. To use the measurement. All right. So anyway, we're back at it. So we look forward to seeing you next month with a different topic. We haven't quite decided if it's going to be another walk, run, or the jumping. I've been talking about the jumping a lot. So in my course this past semester, and I worked with a group of honor students, so we really kind of dived into the literature again and started that conversation. So, all right, I think that's about it. And Theodore, welcome to the United States.
And good luck.
That's right. All right.
Okay, so stay tuned to us. We're gonna send, within a couple of weeks, we will send the invite for the new session of February. It's on the second, always on the second Thursday of the month at 7 p.m. Paris time.
All right. So over and out.
You have my email, so if you have any questions, don't hesitate to share them, and I will share them with Chris. Okay. Have a nice evening, everybody.
Thank you. Appreciate it.
Bye-bye.